Hello, welcome to our online training, Appointment Systems, Determining Capacity and Demand. My name is April Pace and I am the Vice President for CARDIA. On behalf of the California Primary Care Association and CARDIA, we are pleased that you've selected this module to support your professional development. CARDIA is a nonprofit, mission-driven organization with a principal team of committed and passionate staff who have dedicated our careers to helping health and human service providers offer the best to their patients. You may be aware that CPCA is offering this training as part of their patient-centered Health Home Recognition Program. This initiative is designed to support the efforts of member clinics as they move toward achieving National Committee for Quality Assurance recognition. CPCA has made a commitment to support community clinic and health centers in California to become a patient-centered health home. For more information, visit their website. Let's review the objectives. At the end of the module, you will be able to determine your site's capacity for appointments, identify key factors to consider when designing an appointment system, and recognize the information and communication needed for appointment system success. Why is this important? Because our patients use our services when they are highly satisfied. This satisfaction is based on the relationship with provider care team. Patients will comply with their medical advice most successfully when they have a strong and positive relationship with the provider and care team. Availability of care. Patients want easily accessible service that includes convenient hours of service, quick service, the ability to get in and get out, and available appointments when they want and need them. Finally, they want quality. Patients deserve safe, respectful, and culturally appropriate care, such as high-quality service and supplies, respect for the reality of patients' lives, clinically trained staff, appropriate follow-up, and language services. Scheduling an appointment may be the first contact a patient has with the clinic, and first impressions count, since patients remember and value the treatment they received during the process. Simply put, an appointment is an agreement between two or more people to meet at a defined time to perform an agreed-upon task. And your appointment system is key to making all of this work. We know that managing a clinic is complex, and focusing on the appointment system is just one component of ensuring quality of care. Many leadership teams use clinical process improvement to ensure quality, access, and reliability of care. Again, this focus will result in improving the patient care experience. Clinical process improvement, also known as quality improvement, is a process that strengthens organizational capacity to measure, evaluate, and enhance clinic processes and systems. Ultimately, these improvements contribute to better health outcomes and reduced and controlled costs. In addition to the quality improvement framework, there are also standards outlined by the National Commission for Quality Assurance for clinics seeking patient-centered medical home status. These standards address all aspects of clinical services, including the appointment system, and many of these you may already have in place. I've listed several standards, such as access during office hours, noted by NCQA as a must-pass. An example is providing same-day appointments. This is also noted as a critical factor. Next is after-hours access. The example here is to provide access to routine and urgent care outside of business hours. Electronic access. The practice provides electronic access for a request for appointments. Continuity of care. This includes monitoring the percent of patient visits with selected providers. Medical home responsibilities, where information is provided about the role of the medical home. Culturally and linguistically appropriate services, where the practice engages in activities to understand and meet the cultural and linguistic needs of its patients. And finally, there's a coordinated practice team. The practice team utilizes a team care approach to provide patient care services. Again, many of these standards are being implemented in your clinic. You can access these standards by using the link listed on this slide for NCQA's Patient-Centered Medical Home 2011 Standards, which provides 8 elements to meet enhanced access. Several of these standards are covered in this module, and we encourage you to access other modules relevant to these standards, such as open access scheduling, and patient satisfaction assessment. Now that we have the framework for understanding the importance of your appointment system, let's roll up our sleeves and jump into looking at the cornerstone of the clinic by determining the clinic's capacity and the demand for services. Capacity and demand is the foundation upon which your program should be planned, implemented, and evaluated. It is therefore one of the first steps in planning your healthcare delivery system. Understanding a health center's capacity to serve the target population is the first step in planning for the delivery of clinical services to the community. Understanding community need allows a program to establish realistic and informed goals for the percentage of the population in need, support the development of an efficient and effective model for healthcare delivery, such as staffing mix, appointment scheduling systems, workflow, policies, and protocols, establishing goals for staff productivity, and project fiscal requirements to promote financial stability. Capacity is the sum total of an organization's resources, processes, and underlying values to inform needed provider and service availability that collectively responds to the needs of the patient population. Understanding client demand for services is equally important. Estimating the population in need of services within a community is also an essential element to understanding what percentage of that need the health center can meet given its capacity. Demand, in the context of this discussion, is defined as a patient's need and request for care. Demand can vary by season, day, and time of day. Because of these factors, demand can be unpredictable and chaotic. Therefore, to address this variability, there must be ongoing discussions by leadership staff and a review of data to reduce the impact of the unpredictability. There is a need to collect data on such things as patient arrival time and service times, patient and provider preferences, punctuality, cancellations, and no-shows. Collection of data will ensure the system is more predictable and measurable. Both patients and providers struggle to balance demand and ability to serve. The concept of demand can be approached from 2 perspectives. This includes determining at what level clients are currently receiving services, to estimating the actual demand for services, including those clients who are turned away or not able to get an appointment according to their preference. So, if the demand for care is greater than the capacity of the system, there will be a delay in providing care and reduced access. If the capacity of a program is greater than demand, then resources are being wasted. When capacity and demand are matched, delays to care are reduced, access is improved, and resources are used efficiently. Again, collecting data and planning will allow clinics to plan for number of visits made by patients, types of care requested by patients, and duration of the visit. Balancing demand and capacity is the key to operating an effective and sustainable healthcare delivery organization. If the efficient strategies are employed, your productivity is increased and you're able to see more patients. In summary, demand is the request for care. Capacity is determined by resources, processes, and values. Demand plus capacity equals the appointment and service, which leads to outcomes that include clinical results such as an increased level of patient and staff satisfaction, improved health status of your patients and the population, and increased financial health for the clinic. Strategies and best practices can help increase access to services by balancing and shaping capacity and demand. These strategies are not only targeted to the appointment system, but can touch on virtually every aspect of the healthcare delivery system. Here are a few to consider, and then I will go into detail on each strategy. 1. Match resources with demand. 2. Remove internally generated variation in demand. 3. Limit appointment types and standardize appointment lengths. 4. Maximize staff utilization. And 5. Review evidence-based clinical and counseling practices. The first strategy, matching resources with predictable variations in demand. Successfully improving access to care requires that provider capacity be available when patients request care. Matching provider and staff schedules with predictable variations in demand facilitates access. It also helps prevent potential mismatches between available staffing and demand for care on a given day of the week. For example, lunches should be staggered to limit disruption in the flow of the clinic. Next, match staff skill level with demand. Are the appropriate staff scheduled to work at the right times? For example, if you know that many patients are coming to the clinic on Monday morning for a pregnancy test, are there enough staff available for the first thing to provide that service? It may also mean cross-training staff. Match roles with demand. This is similar to matching skill level, but think about whether you have enough medical assistants on staff or enough appointment schedulers. Are you losing patients because they don't like the long wait or they can't get through to make an appointment? Match hours of operation with demand. Would your patients benefit from being able to be served during evenings or on the weekend? Do you serve a lot of teens who need after-school hours? The next strategy is remove internally generated variation in demand. Identifying and removing internally generated variation in demand is critical. For example, a program may only provide HIV testing services to their patients on Friday because that is when the HIV test counselor is available, resulting in severe limitations in the availability of the service. The cross-training of additional staff members to conduct HIV testing throughout the week would alleviate this provider-created barrier to care. Limit appointment types and standardize appointment lengths. A health center's appointment system is the gateway through which patients access clinical services. Ensuring that access is maximized through the scheduling template and scheduling practices is crucial to both meeting demand and operating at capacity. When scheduling templates are crafted without information about capacity or demand, the likelihood that it will be balanced is diminished. Standardizing appointment lengths and types is an important step to increasing access. Numerous appointment types and lengths result in delays in client access to care by requiring them to wait for a specific appointment type to be available. In addition, complicated appointment rules create serious frustration for scheduling staff and increase likelihood that a mistake will be made in scheduling. Standardizing appointment length to 15 minutes, except for procedures which can be scheduled at 30 minutes, also simplifies the appointment process. While 15 minutes may seem insufficient for complex patients, most providers are able to catch up with appointments requiring fewer minutes. Maximize staff utilization. The management of your agency must make the complex decisions related to desired clinical productivity and estimate the number and types of appointments needed each year. This estimate is the foundation of your appointment system. It is critical to know this to determine appropriate revenue. You must know your desired production in order to know if you have the correct staffing and other resources to accomplish your goal. Productivity estimates are often made based on the following variables: grant expectations and commitments, revenue generation, current staff and system capacity, productivity history. Task shifting is one way the public health community has addressed this issue head-on. Task shifting involves a process of delegation whereby tasks are moved, where appropriate, to less specialized health workers. By reorganizing the workforce in this way, task shifting presents a viable solution for improving healthcare coverage by making more efficient use of the human resources already available, thereby quickly increasing capacity. And last, evidence-based clinical practices. Incorporating nationally recognized clinical recommendations offer health centers new opportunities to streamline service delivery systems. In addition, they offer programs an opportunity to reimagine and redesign how services are provided to patients. Well, are we done? No. How do we know this works? We use a process that requires continuous analysis and is integrated into the operational management of the clinic. The Institute for Healthcare Improvement's Model for Improvement provides a framework to accelerate change for improvement in clinical services. The initial approach includes 3 questions. What are we trying to accomplish? How will we know that a change was an improvement? What changes can we make that will result in an improvement? The second focus of the framework has an emphasis on testing changes on a small scale using Plan, Do, Check, Act. This is a scientific approach for action-oriented learning. In other words, making changes is somewhat trial and error. By implementing modifications in phases and for short time frames, staff can assess the success of the change and revise the modification as necessary until the desired result is accomplished. When staff know a change is just a trial and not necessarily permanent, they will be less hesitant to try new approaches. Now I would like to highlight ways to measure demand and track capacity. There are a variety of data that will help determine capacity and demand. Internal data can include tracking the volume of clients that call in to request appointments, the number of walk-ins, the number of referrals, and/or the number of clients with appointments who show at the clinic. External data may also be collected, looking at community demographics, race, ethnicity, morbidity, mortality, income, and health disparities. The first tool is calculating capacity for visits. Calculating capacity can be made based on the following variables: grant expectations and commitments, revenue generation, current staff and system capacity, productivity history, and revenue needs. Calculating capacity for visits. This would be a good time to pause and access a calculator. This will help while I'm walking through this example. For this example, we will assess provider availability. Start with the workdays and hours of operation. Assume for this example a 40-hour work week for the year, or 52 weeks. Next, to calculate the number of work hours per year the provider is available to see patients, we can exclude annual leave, continuing education, and administrative time. Of the 52 weeks per year, we subtract 2 weeks vacation, or 80 hours, 5 days of continuing education, or 40 hours, and 1 day per week administration time, 8 hours times 50 weeks equals 400 hours. Total hours provider is unavailable to see patients is 80 hours of annual leave plus 40 hours of continuing education and 400 hours of admin time, equaling 520 hours. Total work hours in a year is 2080. We then subtract 520 hours of provider time unavailable to see patients, and total hours to see patients equals 1,560. Finally, to calculate the number of patients a provider can see, take the average time of a provider with patients, 15 minutes, or 4 visits per hour. Multiply by total hours, 1,560 available, and that equals 6,240 patients a year. This is a simplistic method to calculate total visits. Assume then in a large clinic these numbers are multiplied by total providers. Then you must determine revenue generated by each visit. Cost analysis is another session and should be covered at a later time. Now it's important to set standards of productivity, since this is the target for number of patients to be seen. After calculating capacity for visits, it is helpful to review ways to increase productivity. One approach is to set standards with staff, track this productivity, and report back. Productivity increases where there is adequate staff support. Providers need the support of RNs or medical assistants to create a team to provide comprehensive care to patients. Providers can help set the appointment system by participating in a discussion about how long visits should be, depending on the client's needs. Have a minimum of 2 exam rooms per provider to allow the provider to move from one room to the next without waiting for patients to vacate the room or undress. Have supplies and equipment where needed. Going in and out of the exam room is inefficient. The provider should be charting during the visit or immediately after near the exam rooms. Of course, if you have electronic health records, this simplifies this important task. Lots of people can do lots of tasks. Expand thinking about who needs to do what, and thinking about shared workload by even distribution of work is the only way to keep up. As mentioned previously, consider organizing cross-functional care teams. Narrowly defined jobs result in handoff, and this extends the time and causes a patient to wait. Another effective method can be team huddles, to check in on who is there on a particular day and any special needs or circumstances that may come up during the day. There are a number of ways to estimate future demand. I previously referenced using internal data to help anticipate demands, such as appointments, number of walk-ins, number of referrals, and show rate. Data can be collected using a very simple tracking sheet for a week at a time or over a month to identify trends and variation over time. We'll now review a formula that offers another way to estimate future demand based on current level of service delivery by provider. We start with N, or the number of unduplicated clients each year. For this example, let's assume N equals 2,500 unduplicated clients seen per year. We can then assume on average each client makes 2.6 visits each year. This is our variable A. To get our variable V, or the total number of client visits each year, we multiply the number of unduplicated clients by the average number of visits per client. In this example, N is 2,500 unduplicated clients, multiplied by A, 2.6 visits each, equaling a total of 6,500 client visits per year. Finally, variable C is the number of clinic sessions, or days per year. We'll assume there are 200 clinic sessions. To calculate the number of clients to be seen to support a session or day, we take V divided by C, or 6,500 visits divided by 200 sessions. This clinic sees 32.5 client visits per session. Now you must decide whether your clinicians can support this demand. We will assume that each session is an 8-hour day. The 32.5 clients seen per session is then divided by 8 hours, and that will equal approximately 4 clients per hour. Remember when I discussed productivity standards and costing? This information must be used here also. If your productivity standard is 4 client visits per hour, then this supports your demand. If your productivity standard is more or less, then you adjust. There are many important considerations to estimating demand: funding, overall operational budget, number of clinical staff, productivity, and community demand. Before closing out this area on tools to measure capacity and demand, a quick note about electronic health records. Electronic health records have the ability to generate reports, but they can be labor and time intensive to customize. It is important to work closely with the vendor or specialist to gain the knowledge necessary to generate reports that capture the desired information. Each electronic health record is different in its reporting capabilities. Therefore, being familiar with what your EHR can do is necessary when designing reports. The Institute of Medicine has outlined 8 core functions of an EHR. These functions are collecting health information and data, result management, order management, decision support, electronic communication and connectivity, patient support, administrative processes, and reporting population health. We will close out this module with a review of the 5 key steps to achieving an appointment scheduling system that maximizes staff productivity and client access. The following are the key steps: developing client visit and unique client program goals that meet budget requirements. Assess clinic capacity and demand, including the number of providers and the number of exam rooms. Select schedule methodology. Select schedule approach. And finally, incorporate scheduling principles and best practices that promote efficiency. The first step, program goals and fiscal sustainability. Program leadership, including providers, need to be aware of the program's visit goals. This includes funder goals as well as revenue goals to achieve fiscal sustainability. This can be done in the method referenced previously. Capacity and demand. As mentioned previously, an efficient appointment template matches capacity and demand. The appointment template should provide a smooth flow of clients to achieve each provider's capacity. Agreement on the capacity of the provider is critical for staff support and success. We covered how provider capacity is determined, and based on this agreement, the template will need to be designed to achieve this level of capacity. Now a shift to schedule methodology and models. There are a number of considerations when selecting a schedule methodology, and you've probably thought about and tried many of them. How long should each slot be, and should they all be the same length or different lengths? Should you have a block system where all patients are scheduled to come in at 9 a.m., for example, and they are all seen in some predetermined order by the end of the morning clinic? What about a wave or modified wave system? Two different types of patient visits are booked at the same time. Patients are scheduled earlier in the block so providers can use the rest of the block to catch up. And lastly, there's the stream system, where patients are scheduled throughout the day and are given equal length appointments. We'll look at each of these in a little more detail. The length of your appointment slot. There are single length appointments where all the appointment slots are the same length, and there are multiple length appointments where the slots vary depending on the visit type. What do you have in your practice? Do you know what considerations management had in making this decision? Think about the possible pros and cons of the two different approaches. If you're watching this module with a coworker, consider hitting pause for a minute and discussing the pros and cons of the two approaches, or just the one approach you use in your practice. Here's what we came up with. You can see how they compare to your thoughts. Single length has been found to simplify the appointment making process. The receptionist spends less time doing phone triage to determine what kind of slot to give the patient, thereby speeding up the process. Some visits will be shorter while others longer. They tend to balance each other out. One might be concerned about the patients who need more time, completely throwing off the schedule, but ideally, the visits that take less than the allotted time balance out the schedule. What about the appointment slots that vary? A revisit might be 15 minutes and a new patient might be scheduled for 30 minutes. So theoretically your schedule matches the length of the actual visit. Or does it? There are obviously multiple factors that can throw off visit length. So this type of schedule doesn't necessarily guarantee that the slot will match the visit. With this type of system, the schedule is typically filled in advance. The length of the visit can be a bit more predictable. However, the schedule is more restrictive and less accommodating to the patient's needs, because if you only have certain visit types available, the patient's needs may not match the visit. Finally, this approach typically requires more extensive phone triage. Within the block system, the focus is on when the patients arrive. All patients are told to arrive at the same time, and the goal is for them to be seen within a particular block of time, such as all during the morning clinic. It can be challenging, but the benefit is that it requires very little administrative effort, and it's a little more predictable than a straight walk-in system. So if walk-ins are what you've been doing, this could be an improvement for you. The downside is that there are typically long waits for the patient, and the clinic can be quite chaotic at the start time. It can relieve some of the pressure on staff, but it is not very patient-centered. If the block starts at 9 a.m. and some patients come early, a patient arriving at 9:05 could be the last in line and could not be seen for hours. Moving along that same continuum with the wave system, sometimes called the modified wave system. Patients are typically double booked and longer visits are scheduled at the same time as shorter visits. I know many of you have gone to your own doctor's appointments where at times you've noticed that another patient has signed in with the same appointment time and with the same doctor and have wondered who's going to end up waiting longer. Well, ideally, you're both served by someone at the scheduled appointment time. Usually the way it works is the provider goes in to see the shorter visit right away, while the medical assistant is beginning with the longer annual visit that's been booked at the same time. No appointments are scheduled during the later hours, so providers can use the rest of the block to catch up. This method allows for smoothing out the schedule and it can be flexible, but it can also be chaotic, and there could be long patient waits. The stream system is appropriately named because it creates a steady stream of patients throughout the day, and each patient is given the same length appointment. The good news about the Stream system is that there is very limited double booking, and it's the best way to limit patient waiting time. The challenge is that there is sometimes limited time for the provider to catch up if they encounter a patient that takes longer than expected. Now that I have reviewed the various pros and cons of appointment scheduling methods, I will review the various appointment scheduling models. When we talk about models, we will review three: a traditional model, a carve-out model, or open access model, also known as same day or next day or advanced access. The motto for the traditional model is to do last month's work today. This is because there is typically a backlog of work to be done, but it also refers to the patients who wanted to get in a month ago and are finally getting in today. Each day, the provider arrives to a full schedule. The appointment schedule has a variety of appointment types, or different lengths depending on the reason for the visit. And often patients have been scheduled 2 weeks to 2 months ago or more. Urgent visits are squeezed in. The clinic tends to run late or behind schedule, and lunches are sometimes skipped. High no-show rates occur because patients have been scheduled so far in advance that they often forget their appointments or their need has been addressed. Full schedules lead to increased urgent care clinic visits for those who really need services and couldn't make it onto the schedule soon enough. The carve-out model is an attempt to improve some of the flaws in the traditional model and is sometimes described as the first-generation open access. Its motto is, "Do some of today's work today." With the carve-out approach, appointments are made in advance, and many appointments are carved out for urgent specific types of visits. Triage staff play a major role in determining who gets scheduled when. It's important to estimate the number of slots that need to be kept available for urgent or same-day appointments. It's good and bad news when it comes to access. Patients can get same-day access, but only if they meet the clinic's criteria, or if the clinic is willing to squeeze patients in. Patients who have non-urgent needs get bumped into the future, so work is delayed. Also, slots may end up unfilled if you don't end up accurately predicting or if the right slot is not available for a patient's need. For example, a slot held for several simple procedures. Appointment staff tend to tell patients to call back on the day they want to be seen because they can release some of the slots they have been holding for same-day appointments. But this can impact the phone system when you have patients calling back twice as many times as they should. Additionally, staff are tempted to steal future reserved urgent slots because no other time meets the patient's needs. Both of these practices interfere with attempts to accurately predict true same-day demand and create future scheduling problems. It's quite easy to end up returning to a traditional model with a saturated schedule. The model for open or advanced access is for patients to be seen when they want to be seen by the provider of choice. There is no distinction between routine and urgent appointments, so you don't have to be really sick to be seen that day. And because patients can be seen on the day they call, they ultimately have greater access. Instead of phone staff asking the reason for your appointment, they ask, "Who's your provider?" because the reason doesn't influence the scheduling. Other advantages of the open access model are that providers see their own patients. As we mentioned earlier, because there is this increased effort to make sure patients see the same provider, patients have more established relationships with their provider, more time to provide extra services for them for which you can bill, and patients are more satisfied. Lastly, the show rate tends to be better because appointments haven't been scheduled 2 weeks or 3 months in advance. In addition to the no-show rate being lower, because fewer patients are forgetting about their appointment, there tend to be fewer cancellations, since there is less time for a scheduling conflict to surface. Patients are more certain about their ability to keep their appointment at the time that they schedule it. With the Open Access, you don't have to hold appointment slots open to meet same-day needs because you've gained capacity that you didn't have before by doing today's work today. At least 50% of appointment slots are open at the beginning of the day. Because the majority of the appointments are made the day before or on the same day, staff do not have to spend nearly as much time making reminder or confirmation calls. Therefore, their time can be spent doing some tasks that contributes more directly to patient care. Having appointment slots that are all the same length is a characteristic of Open Access model. Single length appointments have been found to simplify the appointment making process. The receptionist spends less time doing phone triage to determine what kind of slot to give the patient, thereby speeding up that process. Some visits will be shorter while others are longer, but they tend to balance each other out. One might be concerned about the patients who need more time, completely throwing off the schedule, but ideally, the visits that take less than the allotted time balance out the schedule. I want to close reviewing the best practices that result from diligent work in estimating capacity and demand for your appointment system. Increased appointment availability, ability to manage show rate, plan for contingencies, develop appointment policies to ensure consistency, reduce schedule complexity and restrictions, and develop appointment template schedules. Further, client arrivals should be based on the time allotted for the complexity of the visit. Review of customer service skills is essential, and a call center or dedicated staff member is helpful. This concludes our online training session on appointment systems, determining capacity and demand. References can be found on the following slides. Again, this webinar is part of a series of online courses provided by the California Primary Care Association as a demonstration of their mission of strengthening its members' clinics and networks through advocacy, education, and services in order to improve the health status of their communities. For more information on CPCA and its services, please visit www.cpca.org. For other online training opportunities, please visit the websites for California Primary Care Association and CARDIA at www.cardiaservices.org. Thank you for your participation in this web-based module.